Mr. K is an 85-year-old man with severe degenerative joint disease, diabetes, and heart failure. After a period of 3 weeks with home health care, Mr. K called his doctor complaining of chest pains and swelling in his legs. The doctor sent Mr. K to the emergency room where he was admitted to the hospital and released after a 3-day stay. His primary diagnosis while in the hospital was heart failure. At the Resumption of Care visit, while completing the agency's Resumption of Care evaluation, his home health nurse, Sue, notices that the swelling in his legs has improved significantly. She also notes that there has been a change in the medication Mr. K was taking for his heart failure, with the addition of an ACE inhibitor, which is a new medication for Mr. K. Since there have been changes to his medication regimen, Sue provides instructions on the use of his medications again. Mr. K rates his pain as a 3 on the 1 to 10 scale. He also reports the pain is less since he's taking the pain medication at regular intervals. He has been using naproxen sodium 250 milligrams by mouth twice a day and acetaminophen 500 milligrams by mouth every 6 hours as needed when the pain gets worse. The doctor has prescribed the use of a walker for Mr. K until his next appointment. He has not used a walker before, and Sue notes he's a bit unsteady when he arises from the chair and starts to walk.
I saw Mr. K today, and I have some questions about how to complete M2400.
Sure, let's see what I can do to help you with these.
He's a diabetic, so I know I have to include orders in the plan of care for monitoring his lower extremities for evidence of skin lesions, and I also have to include patient education on proper foot care.
Right, our electronic health record helps to populate that field when you identify diabetes, but check to make sure it's incorporated into the physician-ordered plan of care for the resumption of care.
Well, he has a new walker, and he's a bit unsteady on his feet, but I wasn't sure which falls assessment to use. I heard we're transitioning to a new one.
The training will begin next week. For now, just use the multi-factor falls risk assessment that includes the timed up and go and the other questions related to medications, past falls, and medical diagnoses associated with falls.
Okay.
You should put a note in the record that on the next visit, he needs the multi-factor falls risk assessment done. Let's add falls risk interventions on the plan of care anyway, though, since the new walker and his unsteady gait put him at risk. Then we can do the multi-factor falls risk assessment to determine how at risk he is and if there are other interventions needed.
Okay, got it. Now about his pain level. With his usual meds, he rates it as a 3 on a 1 to 10 scale. What do I do with that? It's not severe pain.
Remember, for our agency, pain is the 5th vital sign, and we assess it on each visit. So you'll want the plan of care to indicate assessment of pain on every visit, evaluation of the effectiveness of medications he's taking, and instructions on his safe use of medication for pain, particularly the acetaminophen. You might also think about adding some non-pharmacological interventions if he's receptive to those.
Great, that's what I was planning for that one, so I've got it. I have a call into the doctor to discuss the plans for Mr. K, and so I'll let you know if anything changes. Hi, I saw Mr. K again today, and I have a couple questions for you.
Sure, what can I do to help?
I did the multi-factor falls risk assessment this visit, and he scored at a high risk for falls. He's doing a bit better with the walker, but he's still unsteady, and he's not been able to get into the shower like he did before he went to the hospital. So I really think he would benefit from PT. Should I add that to the resumption of care order?
At this point, because this is a resumption of care, the 2-day window has closed, so we can't add to the original ROC orders. But go ahead and contact the physician by phone regarding your findings, request a PT evaluation, and ask about the falls prevention protocol we use with home evaluation and safety instruction. This is a good time to use the SBAR process. Remember, we just talked about that at last month's staff meeting. Situation, background, assessment, and recommendation. If the physician says okay, then record the verbal order. How's Mr. K's pain level?
No changes there. The current meds work really well for him.
Well, that's good. Any other questions?
Nope, that's it.
Hi, Ann. I was hoping to talk to you about Mr. K. He's ready for discharge, and I have some questions about how to answer M2400, the Intervention Synopsis, since I didn't do the ROC and have only seen him a few times.
Sure, I'm familiar with him somewhat.
Okay, so I understand that the diabetic foot care was identified at the ROC and was on the plan of care. I see from the clinical record that he was regularly assessed for skin lesions on his lower extremities and was instructed on proper foot care. So I mark 2400 row A as yes, right?
That's correct.
For the falls risk assessment, I see that on the second visit we did the multi-factor assessment and found he was at high risk. So she contacted the physician for a PT eval and used our falls prevention protocol orders.
She also should have falls risk assessment and interventions on the verbal order after talking with the physician. Did the physician okay the PT eval and the fall prevention protocol?
Yes, it was sent as a supplemental verbal order. And from the clinical notes, PT did their assessment, provided instruction, worked with him on safe transfers, walking, and use of the walker. I see from the clinical notes that skilled nursing followed through with the other pieces of the falls prevention protocol we used for medication evaluation for medications associated with falls. So for M2400 row B, I mark yes?
Correct, because we have the supplemental verbal order and the orders were implemented.
Okay, now for the pain. This is confusing to me. Initially his pain was mild and he rated it as a 2 or 3 on the 1 to 10 scale. Does the 1 to 10 scale really qualify as a standardized validated measure?
Yeah, it sure does, because it was appropriate to this patient. And remember, there's a difference between how M1240 is answered and what we do with patients who have any pain. M1240 asks about severe pain, whereas M2250 and 2400 indicate that patients with any level of pain should have assessment and monitoring. That's why our agency policy indicates that we assess for pain on each visit as the 5th vital sign. How did his pain change over the episode?
Poor guy ended up with shingles and had really bad pain for a couple weeks. The doc put him on an antiviral as soon as we saw it, but his pain was really bad for a couple days. Then the doc put him on gabapentin for some postherpetic neuralgia. It's much better now, but I'm confused as to how I mark row D since his pain was mild at first.
On the physician-ordered plan of care for the resumption of care, was there an indication that pain would be assessed at each visit and there would be ongoing evaluation of the effectiveness of the pain meds and so on?
Yes, that's all there.
And are there phone notes with the physician regarding the development of the shingles, verbal orders for follow-up and extra visits that include assessment of the shingles progression, the new meds and plans for monitoring how well the meds were working for both the shingles and the pain? That's all in there?
Yes, that's all there too in the verbal orders and the clinical notes.
So because the information was on the physician-ordered plan of care for the resumption of care, and there was ongoing assessment and evaluation, even without his developing the shingles, you could mark row D as yes, because there were orders and the orders were implemented.
Okay, that is what I thought, but then I was not sure because of the shingles piece. Now my last question. I thought Mr. K seemed a bit down, so I did the depression assessment. He scored a 3 on the PHQ-2, so I contacted the doc, who essentially said okay, but did not do anything about it. I tried a couple times to get the doc to see him or refer him, but the doc was not responsive to this. At the last visit, I did the PHQ-2 again, and the patient was better. He had a score of 1, so I'm not worried about discharging him, but I am frustrated that I saw something that needed intervention and could not get a response from the doc.
I understand your frustration with Dr. Smith. You did the right thing by doing the depression screening and following up. And I'm glad to hear Mr. K is better. Did you document your contacts with Dr. Smith?
Yes, I did.
Just to be clear, did Mr. K ever indicate he was a risk to himself or others, like suicidal ideation?
No, never. Just some reaction to how sick he was when he was in the hospital and how he was concerned that he was never going to be back to how he was before he went in because of his heart failure.
Okay, just checking to be sure. For M2400 row C, you mark no, since there were no orders and nothing was implemented.
But we did all the right things for this.
Yes, we did, but M2400 requires that there be orders in the physician-ordered plan of care and that the interventions be implemented. But since there were no interventions ordered by the physician, the correct answer is no. Have I shown you these flow diagrams for M2250 and M2400 that were included in the April 2010 Q&As? This one shows how, for M2400, if the patient had a formal assessment and it was positive, then there would need to be interventions in the physician-ordered plan of care in order to say yes. Here, you can have this for future reference.
Okay, thanks. But if I say no on this question, won't our agency be dinged if the surveyors come in and find Mr. K met the criteria for further workup and nothing happened?
No, this is where your documentation of your conversations with Dr. Smith are critical to indicate that you brought things to his attention and that he wouldn't provide additional orders. Now, what about row E for pressure ulcers?
Well, he was assessed but not at risk.
All right, so that one is marked NA like the other ones in the M2400 because he was assessed but determined to be not at risk. Remember, NA is only an appropriate answer if you did a formal risk assessment. If you had done an informal assessment, it would be answered no. But you did a formal assessment, and that means rows E and F should be marked NA.
Got it. Thanks for your help.
My pleasure.
The scenario you just viewed began with some examples of how to complete M2250, the Plan of Care Synopsis item, when the OASIS-C dataset is completed at resumption of care. Our clinician reviewed the findings of her patient assessment and used those findings to construct a plan of care that addressed the patient's needs. These needs included an unsteady gait that contributed to a risk for falls and pain that was not rated as severe but required intervention nonetheless. The supervisor reminded the clinician that their agency views pain as the fifth vital sign and assesses for it on each visit. Therefore, physician orders in the plan of care for this patient will be developed to indicate assessment of pain on every visit, evaluation of the effectiveness of medications the patient is taking, instructions on safe use of medications for pain, and possible non-pharmacologic interventions if the patient is receptive to those. If the 2-day resumption of care window has closed when the orders are received, they can be added to the plan of care as a supplemental verbal order, but would not be counted in M2250. The scenario concluded with a look at some of the challenges of completing M2400, the Intervention Synopsis item, at the time of discharge, particularly when the clinician completing the discharge is not the same one who conducted the original start or resumption of care assessment. The supervisor confirmed that for this patient, the appropriate answer for row B, falls prevention interventions, was yes, since even though the original plan of care did not include falls risk interventions, there were supplemental verbal orders for a physical therapy evaluation and falls risk interventions, and the clinical notes documented that the ordered interventions had been implemented. The clinician was disappointed to learn that even though she had done a depression assessment and contacted the physician in an attempt to address the patient's depression, row C had to be marked no, since no interventions were ever ordered or implemented. When reviewing the correct response for the pressure ulcer rows in M2400, the supervisor reminded the clinician that NA, or not applicable, is only an appropriate answer if a formal risk assessment was completed. She also reminded the clinician that CMS does not have an expectation that agencies will achieve 100% for these best care practices. Clearly documenting conversations with a physician in the care notes is important for showing that the clinician brought their findings to the doctor's attention, even if the physician decided not to provide additional orders addressing those findings. The supervisor referred to information in Section P of the OASIS-C Guidance Manual and the M2400 flow diagram to determine when no, yes, or NA is the appropriate response. The manual is available for download from the CMS website. The flow diagram can also be found at the address shown here.